recently been told that ophthalmology not only is the busiest outpatient specialty, which is something we've been told by many different organisations for many different years, but we're also the specialty which has the longest waiting list. And a significant factor in this is our workforce challenges, because we know that across the country, departments are facing workforce challenges with recruitment for not just consultants, but also training numbers are something that we really need to see increasing. Allied health professionals, including nurses, optometrists, orthoptists, and the wider team and the wider scope of these colleagues as well. So today, we're going to hopefully have a broad mixture of talks from people across the whole country, and we're hopefully going to start a conversation as to how we can help to address these problems. So can I just get the next slide, please? So just a bit of housekeeping before we get going. If it's okay for everyone just to stay on mute unless you're speaking, because sometimes we get lots of echoey issues and other problems. It'd be great to avoid that. I'm just seeing a desktop at the moment. I don't know if Carrie, if we can go back to the slide, that's perfect. At the end of all the sessions, we'll have a group discussion where hopefully some of the questions that have been shared in the chat, we can go through and discuss them. And we've got lots of people already joining the meeting, including the president of the Royal College. So maybe we can call across Ben Burton for maybe some of his opinions on some of these issues as well, without hopefully putting him on the spot as well. If you have any comments or questions, please do put them in the chat throughout the meeting. And if you are enjoying the meeting, please do tell your colleagues about this organisation, the UKOA, and tell them about this meeting and recommend to them that they can go on the website afterwards and watch a recording of the meeting. Just get the next slide, please. So today we're with you until 2 o'clock. We're going to give a very brief update about the UKOA, and then we've got some news from the College of Optometrists as well. But our first speaker will be Jordan Marshall, who's joining us from the college, and I'll introduce him shortly. If we go to the next slide, please. So the UKOA has meetings until October 2024. The next couple will be virtual, but we do have a face-to-face meeting in London scheduled for the end of April, and that looks like a really exciting and interesting agenda. So I'd really be great if as many people as possible could register and join us for this. I think there are some membership issues. I know, Alison, if you'd maybe like to comment on this at all, but I think if you do value what the society does and what we do as an organisation, and you're aware that your department and organisation hasn't paid their fees, please do speak to your manager or your clinical lead to see how they can best support the organisation. Most important thing for the whole meeting, I would say, is that if the scope of the UKOA is to promote standardisation, best practice, innovation, supporting clinical outcomes, improving efficiency, not just in clinical care, but in cost. If you have any suggestions or ideas, or even want to co-chair or support an event in the next year, please do get in touch and either put a message in the chat and we can get back to you, or email the UKOA inbox. Could you get the next slide, please? The next slide. Yeah, so these are just an overview of the next meetings. And so the next meeting, which is face-to-face, which is the one I mentioned, is 2024, Thursday, 25th of April. So maybe while we're on this slide, if everyone can put that in their diaries and take all the necessary study leave, annual leave that you need to, that would be great. Next slide, please. And this is just a message from the College of Optometrists that they wanted us to share. They're going to be speaking at our next meeting in February, which is virtual, but they're doing a significant amount of work at the moment where they're looking to develop a dashboard to model which conditions are most important, what do we see the most, how these conditions will change in the next 5 to 10 years, and that will hopefully help us with guiding training, development, workforce strategy, and capability in ophthalmology and optometry together. So what I'd like to do now is I'd like to introduce our first speaker, and I'll just move on to the next slide. And Jordan Marshall works at the Royal College of Ophthalmologists. He leads the policy work at the college. Prior to this, he's worked in roles in the health, energy and business sectors, and today he's going to be talking to us about the 2022 ophthalmology workforce survey findings and provide some context as to all the work that's going on at the moment in terms of workforce. So I'll hand over to you, Jordan. Thank you.
Thanks very much for that intro, Sunil. I could probably speak for a long time about all these workforce stats because they are really interesting, but I will try and limit myself to 15 minutes or so, and I'll have to take questions then or after the other talks, whatever is easiest. So if we go on to the next slide, I'm sure a lot of you know who we are already, but if you don't, we are the membership body for the profession in the UK. We do lots of good things, as you can see from these icons here, including producing clinical guidance. We run a census every so often, which I'll go through. We have an annual conference, which this year is in Northern Ireland, and we also work quite closely with policymakers to try and improve the environment around eye care. So if we go on to the next slide, I'll talk a little bit about what this census we conducted was. So it was quite exciting because it's the first one we've done since 2018. So obviously a lot has changed in ophthalmology since 2018, not least the pandemic and many other changes in how services are commissioned and run. So the way that we did it is we asked all of our members lots of questions about their working role, but then we also asked clinical leads in each NHS ophthalmology department to speak more broadly about some of the issues going on in their unit, including around waiting lists and the independent sector, which I will get onto. So the next slide, please. So one of the key findings is around workforce shortages, which will probably not come as a surprise to you. So next slide, please, Carrie. So we asked the clinical leads if they had enough consultants, SAS doctors and trainees to meet current patient. And the key finding here is that they didn't, especially when they were asked about consultants and SAS doctors. And the other interesting thing is high reliance on locums. Around about 2/3 were using locums, and the majority of those who were using locums were using them for over 12 months. So can you move on to the next slide, please? And another huge issue is around recruitment and retention. This again will not come as a surprise to many of you. And the thing that's worth flagging here, I think, is that retention came out as a particularly big issue. So 2/3 had found it more difficult to retain consultants compared to 12 months previously. So that was quite a concerning finding. On to the next slide, please. And the other thing we asked about in a little bit of detail was around outpatient backlogs. So to give a bit of context, ophthalmology waiting lists have gone up a lot compared to pre-pandemic. So we had a little over 400,000 in January 2020, and 3 years later we had well over 600,000. So that gives some sense of the demand on ophthalmology departments. Next slide, please. So to give a bit of context to that, when the latest stats came out a couple of months ago, we saw that in England we had over 8 million outpatient attendances, which was a really big jump just on the year before, and it also bucked the trend of the wider NHS, where outpatient attendances were not really up by very much at all. So ophthalmology is seeing a lot more demand compared to other parts of the NHS. And I also thought it's worth noting here that we are relatively understaffed if you look at the number of doctors we have compared to that overall demand, and also international comparisons of ophthalmologists per head. Next slide, please. So, as I said, we got into a little bit more detail about these outpatient backlogs, and the huge majority said that they were more concerned at the state of the outpatient backlogs than they were 12 months previously. We asked them how long they thought it would take to get through these backlogs, and a big majority are saying it would take over a year. We then asked them to look at each subspecialty and to outline how concerned they were about the backlogs in each of those, so we have a bit more information about exactly where the problems were.
Hi everyone, sorry, I think Jordan's internet connection might have just dropped, so I'm just going to try and get in touch with him to rejoin the call in just a moment.
So Neil, I'm just wondering whether or not it might be worth moving on to the next presentation, then we can come back to this one.
Yes, we absolutely can, but I'm just wondering if Adam Mapani has joined yet. I'm not sure if he has.
Or Sunil, we could ask whether we could do it without the video, and you know, that sometimes is easier for the presenter. So if it's the internet connection.
Yeah, let me just.
Or the bandwidth, it just sometimes makes it, because we've got the slides at our end, isn't it?
Yeah.
So.
Has anybody got any questions or thoughts on what's been presented so far? So we can just.
As we were looking at stats and numbers, Sunil, so if we've had 8 million outpatients appointments in the last year, and the backlog is around 600, 700. Is that correct? 600,000? I'm just trying to look at the figures. So are we lacking about 10% capacity or 15% capacity? If you want to minimalize because of the amount of work that we do, then the proportionality of what is in the backlogs at the moment. I was just trying to say that it's not an unsurmountable backlog.
Absolutely.
If you put it in the context of how much we deliver.
Yeah, and maybe some of those small gains that we can maybe implement in practice, which might increase efficiency by say 5-10%, you know, cumulatively, exactly. Maybe they're enough to do something on top of the other things that the college are doing. But what I was wondering, I don't know if Bushra, if you've got any insight onto this, is that what was, you know, Jordan was saying is that ophthalmology's had a big uptick in the demand. You know, Jordan was saying that there's a big uptick in the demand for ophthalmology outpatient appointments, and that's hugely greater than other specialties. And I was wondering whether Jordan or yourself or anyone had any suggestions as to why we have so much more increase in demand compared to other specialties.
I think I can tell you something from the medical retina point of view. So slightly narrower view. Diabetes, for example, increasingly an issue, hence the diabetic retinopathy and the referrals that are coming through, and the severity of referrals, as in the grade of retinopathy at which they are sent in. Increasingly, I think maybe there is more awareness regarding AMD. And again, the referral base is increasing. But, and I don't want to sound as if the technology as it is becoming so much more available, as in OCTs out there, I sometimes see a lot of lower level pathology being sent in, which I think previously was still happening. I'm talking about ERMs and very small little changes, and in some of it, I think can be managed by, once we have the electronic referral system embedded in our processes of keeping some of the work still out rather than allowing it to come in, or different ways of working where some of the lower complexity work can be dealt with in a different way in the community. And that's some of the things that I've been thinking about, really.
Yeah, I mean, maybe at the next meeting in February, the College of Optometrists might be able to input there more as well. But are we moving towards a model whereby there's renegotiation of the GOS contract, there's more responsibilities being put forward towards optometrists in the community with specialist skills? I think Jordan's just rejoined. So Jordan, are you there with us?
Yes, I'm sorry. Sorry about that.
Are you able to maybe without video you could rejoin and see if that's better in terms of the internet or something?
Yeah. Okay.
Without video, yeah, and see how we go.
Yeah. Okay. Sorry about that interruption. So I was speaking about the outpatient backlogs that our members reported, which were difficult across the board, but particularly worrying in some subspecialties. So let's move on to the next slide, please. So we also asked in free text comments for people to highlight some of the other challenges they were facing, and these broadly centered around issues with infrastructure, so a lack of space, both clinic and theatre space, difficulty with IT systems, both across secondary care, but also when trying to communicate with optometry. More broadly, there were some concerns about a lack of investment in their department from their NHS organisation, which also included not being able to use more members of the wider MDT. So next slide, please. One of the other areas that we were interested in asking about was about the independent sector, because between the previous time we did the census in 2018 and 2022, there'd been a large increase in the use of the independent sector in NHS cataracts. So from around about 25% before the pandemic, it was around about half, around about 50% of NHS cataracts were done in the independent sector when we did the census, and now that's risen to around about 58%. So this is an area we really wanted to look at. So we go on to the next slide, please. So this slide is really saying that, first of all, the independent sector is covering most of England, almost all of England. In Northern Ireland as well, there are some independent sector providers of ophthalmology services, but not in Scotland or Wales. So this is largely an England issue that we're talking about. And we asked our clinical leads what had been the impact of independent sector providers in their area on patient care and ophthalmology services in their unit. So what had been the impact that they'd seen locally? And it was a bit of a mixed picture. This chart on the left may or may not be big enough for you to see. But on balance, the leads were more worried than they were positive about this impact. So 58% said that the impact had been negative, and 38% said it had been positive. So on to the next slide for a bit more detail about what some of these concerns were. And I think broadly the worries that came through were about the knock-on effects on the sustainability of their comprehensive NHS service. So there are worries that with fewer cataracts being done in their unit, this reduced the resources available for that unit to deliver the more complex care, which if it wasn't being delivered in their unit, it may not be delivered at all. So that was one of the areas around the impact on patient care. How do we fund and resource this more complex care, whether that's emergency eye care, pediatrics, lots of other areas. One of the other issues was around training, because obviously the training of ophthalmologists has always been done in the NHS. So with so many cataracts, NHS cataracts, leaving the NHS, we've seen through GMC's national training surveys and our own work that ophthalmologists in training have really struggled to access opportunities to do cataracts, especially in the early stages of training, ST1 to 3. So that's an area that has been worrying the ophthalmology community, and it's one we've been doing quite a lot of work on over the last couple of years. One of the other areas is around the management of post-operative complications and whether there are proper processes in place between the independent sector and the NHS to manage where there are complications. And the last issue to really highlight is workforce. We know we don't have enough ophthalmologists as it is. So with the workforce becoming more fragmented, I think that is starting to create problems as well. And that's very variable across the country, but we know there are big problems in certain areas. And for us here at the college, this has been an area that we've been working quite hard on to try and make some progress on some of these issues. As many people on this call will know, there's been a lot of work around trying to improve commissioning, which is ongoing, and also to try and ensure there are more cataract training opportunities in the independent sector. So the next slide, please. So another bit of the census was us asking the ophthalmology workforce to talk about how they were finding their role, whether they were feeling more positive, more negative. So if we go on to the next slide, we can see some of the detail of this. So first of all, we asked everyone to say, on a scale of 1 to 10, how fulfilling their role had been. I think this was quite an interesting to ask. We hadn't asked it in the previous census, so we didn't have great expectation of what people would say. I think the results were more positive than I was actually expecting. You can see the majority of people are saying over 7 out of 10 in terms of how fulfilling their role is, which I think is quite positive. There was a roughly equal split when we asked people about whether their role had become more or less fulfilling. And then when we dug into the reasons for that, workforce shortages were the most cited reason for why people were saying their role had become less fulfilling. Next slide. And as part of this bit of the survey, we also asked people about what their intentions were over the next 5 years. And the eagle-eyed amongst you will see that this pie chart adds up to a bit more than 100% because people could select more than one option. So they could say both, I'm going to work predominantly in the independent sector and I'm going to retire, i.e. they're balancing both in the next 5 years. But anyway, I think there's some really, really important findings that come out of this. The main thing I think is important to highlight is that only 42% said that they would work predominantly in the NHS over the next 5 years, while around about a fifth are saying they will work a balance between the NHS and the independent sector, and around about the same amount are saying they're planning on retiring. So again, I think there are worries here about workforce shortages in the NHS if we look at what people are saying they're going to intend to do. Next slide, please. And again, we dug a bit more into it. So we looked on this scale of 1 to 10, where people were saying whether they found their role fulfilling or unfulfilling, what their future intentions were. And there seems to be quite close correlation between those who are fulfilled in their job and those saying they plan to work predominantly in the NHS, and vice versa. If you look at the other end, people who are saying their role is very unfulfilling, far more of those people are saying they're likely to work in the independent sector. So I think the reasonable hypothesis here is that people are considering leaving the NHS because they're not finding their roles enjoyable for whatever reason. The next slide, please. So probably the most important thing to think about is how can we address these challenges. So if we go to the next slide, I've summarised some of what we see as the key solutions, and workforce is obviously a huge part of this. I think we need to be, as a sector, as an eye care sector, and working with policymakers, trying to define what workforce capacity we need, and that is across all of the eye care professions. So not just from our perspective as ophthalmology, but obviously the other professions that we need, like optometrists, orthoptists, ophthalmic nurses, technicians, and others. I think there is also more that we can be doing around supporting progression for SAS doctors, which is something that we know that the GMC and the Academy of Medical and Royal Colleges is looking at. So we think that's quite a key area as well. I've spoken a little bit around some of the independent sector challenges, and getting to grips with commissioning is clearly going to be really important. But I will spend just a couple more minutes here at the end talking specifically about one of the solutions around increasing training places. So if we go to the next slide, please. So we know that there are more immediate things we can do around workforce capacity, which I think are going to be discussed a bit later. But in terms of what we see as the real long-term solution to having a sustainable workforce, we think that increasing consultant numbers is really, really important. So I think it's good to take stock of where we are actually at the moment. So I've put here what the full-time equivalent consultant numbers are in each UK nation, and you can see that we fall quite a long way short of having what we see as the ideal ratio of 3 per 100,000, and that is particularly the case in Wales and Northern Ireland, where we have under 2 consultants per 100,000. And if we extrapolate out from that, we're looking at a shortfall of around about 340 consultants. So on to the next slide, please. Now, I always am a bit alarmed when I look at this slide. So this is from the ONS, so it's just England, unfortunately, but the same will certainly be true in the other UK nations. But if we look at the age profile of the population and how it's going to change over the next 20 years, I think it is extremely concerning what's going to happen. You can see that in large parts of the country, so in Lincolnshire, East Anglia, parts of the southeast, large parts of the southwest, we're going to have almost half of the population aged over 65. So we think demand is high now. It's going to get a lot greater by 2043. Next slide, please. And it's also useful to take stock of what's happened with our ophthalmology training places. If we go back, please. So we can see that over the last 10 years, not much has really changed in how many training places we're creating each year. We had a bit of a jump in England and Scotland in 2023, which is good, but generally we're not really increasing the pipeline through the training program at the moment. Next slide, please. But I'll try and finish on a bit of a positive note here, which is the long-term workforce plan, which was published this summer, committed the government to doubling medical school places and funding that increase. And it also spoke about a commensurate increase in specialty training places where need is greatest. So I think there is an opportunity for us as a college, certainly, to be articulating the increase that we think is absolutely essential to creating a bit more of a sustainable workforce to meet that demand in the future. And that's something that we're working on now within the college. So I will stop talking there. Happy to answer any questions now or later. Hopefully you found that useful, and sorry for the tech interruption near the start.
Thank you very much, Jordan. Does anybody have any questions that they'd like to message in the chat or ask about at all before we move on? I'm conscious that we should probably spend only a few minutes with questions now, just to allow Adam to give the full time as well. Jordan, there's just one question that I wanted to ask, please, if that's okay. And while you were away, Bushra and I were just discussing the statistic that you mentioned about an 8% increase in outpatient appointments and how that was significantly different from other specialties in medicine. Why do you think that is?
That's a really good question, Sunil. I don't think I have an answer. It is a tricky one. I think so. While one of the interesting things that has happened in ophthalmology is that we have invested a lot of money in bringing down cataract waiting lists. We've actually done better than other specialties. If you look at overall waiting list numbers, we're reducing our waiting list better than other specialties, and I think that's largely because the biggest portion of our waiting list is in cataracts, and that is what we've invested a lot of resource in terms of the independent sector. But I think the flip side of that is perhaps other aspects of ophthalmology have not received the same resourcing or investment, and perhaps outpatient capacity is one of those. It's not immediately clear. I think there was, during the pandemic, there was a big backlog in outpatient attendances, and maybe we're seeing some of that now, but I don't know quite why it differs so much from other specialties.
Just one final question I wanted to ask was, when we think of the independent sector, we think cataract surgery, as you rightly said. Do you think we are going to see a significant expansion of the independent sector into outpatient specialty care?
That's an interesting question. I'm sure Ben will have some thoughts on this. I think it really depends on the policy choices that are made by the policymakers in NHS England and at the commissioning level, and in and in the other UK nations. I think this is where we've fallen down somewhat in the last few years, in that we haven't necessarily properly planned how we want to deliver a service. So I think that's really the key thing. We need to agree what is in the best interest of patient care and a sustainable service, and then design our services accordingly. And we should try and do that on a consistent basis across the country, so that we have a consistent service. So I don't have a good answer. I think that's something we need to agree as a sector. We shouldn't be letting things develop in an uncoordinated way. So I think that's what really creates concerns.
Well, Jordan, thank you so much for joining today. I hope you'll stay till the end so that we can maybe discuss any things. Professor Burton, I don't know if you've got any points you'd like to make on that?
No, well, only that we're at Westminster on Monday, and basically with the eyes have it, and the call is for sort of somebody to be in charge and to have a plan. I mean, it doesn't seem a very big ask to me, but for somebody to be in charge and have a plan. But anyway, we seem to be way off that at the moment. So, but we're working towards having a plan.
Thank you. Lovely. Thank you. Well, I'm going to move on to our next speaker now, who is Adam Mapani, MBE. And Adam is well known, and he is a nurse consultant at Moorfields Eye Hospital. Adam also currently leads the medical retina nursing team at Moorfields, and I'm very thankful to Adam today for joining us today to be talking about workforce transformation and upskilling and retention of nurse practitioners, because we hear lots about the whole multidisciplinary team, but I think it'll be really great to hear from you, Adam, today about your experience in this area. So thank you for joining us.
Thank you so much, Sina, for inviting me, and sorry for logging in a little late because of an injection session earlier on this morning. Yeah, so I'm going to share probably a case study on how we have been developing our nurse practitioners within the medical retina service. Thank you for inviting me. Next slide, please. So I think the key areas that I'll be summarizing is the delivery of care, intravitreal injection pathways, the virtual pathway, and the role of the multidisciplinary component in delivering retinal care. Next slide, please. So we have heard, and we continue to hear a lot around MDT working, and therefore the medical retina intravitreal injection service is highly collaborative, almost like a ecosystem, healthcare ecosystems consisting of nursing ophthalmic nurses, optometry colleagues, ophthalmic technical workforce. Really important to acknowledge them, our volunteers, fellows, consultant leadership, and we work also very closely with patient advocacy societies such as the Macular Society and Diabetes UK, management, clinical administrators, our academic colleagues, and those who also come in as volunteers. Next slide, please. So NES-delivered intravitreal injection therapy, it is a model that is well established over a decade. And based on our outcome data, safety outcome, patient experience outcomes, we can therefore conclude that it's comparably safe, clinically effective, and there's been a huge patient acceptability and also professional acceptability from different professional societies. And it's widely adopted in most eye units in the UK. But however, there is a significant amount of challenges around sustainability and retention. Next slide, please. So we have published this data in the iNews. So this is our safety outcome data from NES-delivered intravitreal injections between 2020-21 lockdown. And from our safety outcome data, just to summarize that, it shows the efficacy of the use of povidone iodine as a caveat. So analysis of our 2-year data showed that at least 50,402 injections were performed and 12 cases of endophthalmitis reported, 1 in 4,000. And therefore, when povidone iodine is applied, the risk of infection is much lower, 1 in 5,000, and it significantly increases with the use of chlorhexidine, where the risk is 1 in 350. Based on this data as well, just out of, in the context of patient engagement, we've also developed a patient information leaflet specifically on the use of iodine, summarizing this for patients on the importance of the use of iodine. Next slide, please. This is our outcomes patient certification data from NES-delivered intravitreal injections. So generally, the data shows that most patients are happy and interpersonal manner by the practitioner. So based again on our training program, provision of information, communication, disease counseling, but supporting the well-being of the patient from a psychological well-being in the injection room, playing music during the injection, practitioner competence, the quality of time. So all these key parameters does show that most of our patients are happy. Next slide, please. But there's real challenge in the real world. And these are some of the challenge on the next slide, please. So we know that there is evidence from research showing that neovascular AMD is an example that requires prompt access. So the earlier treat, the better the outcomes. So there's therefore the need for early diagnosis and appropriate interventions. And we've also seen the introduction on the use of digital technological pathways or enhanced digital pathways such as virtual pathway diagnostic hubs in improving clinic efficiency. And the role of communication is very integral given the maturation of this pathway, where in some cases patients they come in the absence of a clinician, and there's a clear need to communicate the outcomes. And from a therapy delivery, patient outcomes, safety is always our #1 priority. And we've seen the efficacy of the anti-VEGF injections, but then there's the clinic burden and also trying to meet those targets from a health economics modeling. These injections are fairly expensive. Next slide, please. So in the last 2-3 years, during and post-COVID, we have seen the maturation of digital technologies and their application in delivering eye care. And from a virtual clinical pathways on the left-hand side of the of the slide. So patient comes in, they check in, image bundle, and seen by our technicians, and they go home. So this is a typical model of our virtual pathways. So we use an asynchronous model. which means that patient, they come in, they get all these baseline test imaging depending on disease spectrum, wide field imaging, OCT, and patient goes home, history taking. And then retrospectively, there is then the assessment, reviewing all these scans and reporting back to the patient and to the gatekeepers. Next slide, please. But what we also reflect and learn is the impact of enhanced digital virtual pathways, their high volume service creating demands for virtual image reviewers, and therefore there is a need for workforce transformation as well as patient pathway transformation. And the question is, do we have, or at the time, did we have enough virtual image reviewers? And we've also seen kind of like some gaps in terms of digital gaps. Nursing practitioners or those who are involved with delivering of injections with less participation in this pathway. So our approach was to come together in a multidisciplinary team to support nurse practitioners in reviewing OCTs in these virtual pathways. Next slide, please. So this is an audit that we did aligned to the OT alongside my colleague, a clinical educator in our department, to trying to tease out some of the skill gaps within our workforce. So across the trust in medical retina service, we have got approximately 52 nurse practitioners delivering injections, but they seem to fall within different domains. So i.e., we have some that operated band 8A and band 7, and some who are pretty much like or more concentrated on delivering intravitreal injections. So we wanted to clearly understand those gaps. Next slide, please. And from that skill gap analysis across the 52 MRNS practitioners, so we've got category 1, who are the nurse practitioners, band 6, is delivering therapies only. And then the second category are the enhanced clinical practitioners involved in IVT therapies and other extended roles, such as cataract pathways within the medical retina and grading of OCTs. And then the category 3, which are the band 8As and above ACPs, delivering holistic care patient pathway from diagnosis to discharge. And the overall objective for the workforce transformation as part of our strategic objective was to empower category 1 and 2 towards category 3. Next slide, please. So how then do we develop our own in-house talent? So from my thoughts and those of my colleagues, our aim was to focus on skills, having reflected on that skill gap analysis, identifying and developing our own in-house, and not necessarily focusing on the vacancy issue, not how many vacancies, but what are the skills required to meet the demands for the service. And by doing so, hopefully then to unlock potential for untapped treasures where the nurse practitioners would be key in getting multi-skilled in different areas of the service. So therefore, the aim was to bridge the gap between the novice and the experts. Next slide, please. So in order to do that, next slide, please. So we got through some engagement and involvement in trying to understand their needs, the approach to the service. So the question 1 was, what has been approach to medical retina nurse development in the past, and how is this in outcomes? And then with the other questions as well, if you can click off. So has COVID-19 changed the team's approach to nurse practitioner development? And we also wanted to see what were the opportunities for them, particularly the feedback that we have been receiving, that especially those who are mainly delivering intravitreal injection, they would want to see themselves progressing outside the injection room, involved in the entire holistic patient pathway. Next slide, please. Next slide. So in December last year, with the support of our medical retina service director at the time, Robin Hamilton, and then Luke Nicholson took over, myself and my nursing colleagues and management, we came up with the Medical Retina Nurse Development Program, which was launched last year in December. And we came up with 4 study days, and we also partnered with industry. And the aim was to also to reflect on the health education 4 pillars of advanced practice. So our aim was to upskill our nurse practitioners towards virtual reviews. And in the background, at the backdrop of this, some of our nurse practitioners have been taking an online OCT interpretation course to improve their competence with OCT interpretation. So this first study day was to establish patient assessment and digital pathways as competence 1, and we also moved to audit. And in September, we had one specifically on patient communication consent. We see the integrity of consent in the medical retina injection pathways. And then most recently, the 4th competence was on leadership and soft skills development. There was also support online every month to support those who were being trained towards virtual reviews. Next slide, please. Next slide, please. I think we have had this already. So in terms of the competence, just to sort of go through very briefly in the interest of time, the first competence was to look at patient assessment in digital pathway or virtual pathway, upskilling nurses and building confidence to manage stable patients. So we streamlined our low-risk stable AMD patients and also low-risk maculopathy, R1M0. And the areas of focus was pretty much aligned to medical retina treatments, such as the use of anti-VEGF injections, the different products we use in the service. And the second competent was on auditing our service, initiating their own clinical audits. So we also identify a gap with uptake of clinical audits in the medical retina service. So therefore, second competence was to empower our nursing staff to be involved in clinical audits. And then the third competent, which was also a gap, was to empower them towards consent pathway. We see treatment evolution and the impact in these pathways, so i.e. reconsenting patients each time there's a switch or the expiry of the consent. So the integral role of nurse practitioners and allied healthcare professionals in consenting, consent revalidation. And then the 4th competence was on softer skills development. Next slide, please. So this was also aligned to the OPT training program, aligned to the Royal College of Ophthalmology's OPT training curriculum. And each delegate would receive a digital workbook to support the face-to-face meetings and an optional virtual check-in just to see how progress was being made, and also building the understanding of the 4 competence to support them in the whole end-to-end medical retina pathway. So I think this is a really key message in terms of job satisfaction and retention. So when we have practitioners or nurse practitioners involved in the whole end-to-end medical retina pathway, that drive efficiency and also job satisfaction. Next slide, please. So the training and development program, phase 1, we identified 6 ACPs, 6 enhanced clinical practitioner specialists who have completed online OCT interpretation 1-year course. And we also have 12 that had enrolled for the academic year 22-23. And also looking at the OCT interpretation course, some of the gaps that were identified between theory and practical implementation. These were reviewed by us, and we allocated them structured sessions. And very important was the implementation of the low-risk clinical pathways in February this year. Next slide, please. So very grateful again to our medical colleagues, and we had a medical retina clinical lead for virtual pathways. was allocated to work alongside myself to see the overseeing of these patients. And very important again to mention the importance of timetable. So job plans are very challenging to implement. We had to come up with a strict schedule to make sure that the allocated sessions are protected. Mentor and consultant supervision were also allocated to support and build on the confidence. And lastly, the MDT monthly meeting to assess progress is very important again. Next slide, please. So these are the key milestones in the 12-month medical retina development program as part of workforce transformation. We streamlined pathways for stable AMD and low-risk diabetic retinopathy, maculopathy. We now have 10 nurse practitioners who have been signed off for virtual reviews and capacity to improve with backlogs, and 8 are in training. They've just finished, 8 have just finished their course in August 23, and 5 have just started. So this is across our satellites and including Bedford. So the role of our nurse practitioner now is to review those images, retinal image interpretation and grading, training patients based on protocol, writing up clinical reports, but also have that involvement in terms of virtual pathways. Next slide, please. So the impact of nurse development succession planning on patient outcomes. Next slide, please. So there's a transferability of skills, so i.e. provision of information. And this is also the interpretation that we have if we want to reduce unnecessary referral between treatment interval or through our eye casual department. So most of these skills from OCT interpretation, reviewing scans, and either in the virtual or in cataract pathways can also be transferable for telephone consultation clinical pathways, consenting, disease counseling, and lifestyle for diabetic pathways, reporting outcome visits, preparing patients for treatment pathways. Next slide, please. Thinking about the transition from virtual reviews to face-to-face, which I think is very important. We now also have some of our enhanced clinical practitioners who are involved in cataract pathways within medical retina. And our aim is to work towards establishing nurse participation or involvement in retinal therapy unit assessments and decision-making. And then hopefully with that, we also have the integral role of the nurse in consenting patients between face-to-face clinics. Next slide, please. So this is our summary from our experience of nurse allied healthcare professional virtual reviews. Training and development is integral, but there's also something around quality assurance. We have our fail-safe officer that we work very closely with, and I believe that the monthly MDT meetings also provide an opportunity as part of monitoring quality assurance. Digital competence checklist. What I also mean by that, each practitioner keeps their own records in terms of the number of cases that they see, but also from a competence document, they're also able to keep these within their files, just in case each time they also need to move in different services. But there are real challenges, again, on job plans, backfilling during training and after, and current capacity issues. So, i.e., each time there's an issue or crisis in the injection service, it might be much easier for someone to be pulled from the virtual reviews into the injection service. Next slide, please. So these are my acknowledgement, different colleagues that we've been working with, our medical colleagues, nursing colleagues, management, optometry colleagues, and some of our external collaborators. Thank you for your attention.
Thank you very much, Adam. That was brilliant. Does anybody have any questions for Adam at all before we move on? There will be some chance to discuss points at the end as well.
Just to say, Adam, that was brilliant. I think it's part of the bigger problems that we're facing at the moment with workforce. And I think this would be one of the key elements that would help us. And development of ophthalmic nurses, I think you've done an incredible work with it. Well done. Thanks.
Thank you very much.
Only question I have, Adam, is what are your plans for, say, the next 3 to 5 years to develop this further?
Yeah, I think going back again to workforce transformation, you ask a really good question. I think we'd also want to see this being rolled out to most of the nurse practitioners, not just the few selected that I've mentioned, but also being more strategically aligned to the project Oriole. More fields will be moving to the next phase into the new hospital project. But I think with the focus again of digital skills, clinical skills, advanced skills, that would be the next plan and the next stage, identifying those gaps that can also be met by the nursing workforce.
Thank you very much, Adam. So moving on to our next speaker. Our next speaker is Mr. Ramez Borbara. He's a pediatric cornea, cataract and refractive surgery consultant. And Ramez completed his OLT training at the University Hospitals in Southampton. And so earlier on, we heard from Jordan Marshall at the college, who was talking about the need to increase and to lobby for an increased number of training posts. And I think the OLT program fits in really nicely with this, because it's a way in that I've heard that can increase number of training posts, but on a local level. So I'll hand over to Ramez to talk all about this.
Thank you very much, Sunil. Thank you for inviting me to take part in this meeting and tell you about my experience with the ophthalmic local training at Southampton. Next slide, please. So ophthalmic local training is basically doing what OST trainees are doing, but at more of a local level, hospital-based level, rather than deanery, to attain the certification as a consultant, which is called a CSER. The entire ophthalmology training is done in one hospital, usually, especially if the hospital has all the approved, acknowledged subspecialties in the field of ophthalmology. So it should be like a tertiary referral center normally, but it can be done in a smaller units as well, with trainees going into other hospitals to attain other competencies which are not available in their hospital. So it is similar to OST trainees, but the funding, most of the training is done in one hospital rather than rotating into other hospitals at a yearly basis. Next slide, please. So before I tell you a little bit about my OLT experience in Southampton, let's find out what caused Southampton University Hospitals to want to have ophthalmic local training, which we called it at the time CSER training. So at that time, there used to be 6 ophthalmic local trainees, OST trainees, sorry, 6 OST trainees, deanery trainees, which were actually pulled out of theater sessions quite on regular basis to cover casualty, to cover retina clinics, where there was sometimes understaffing, glaucoma clinics, and they were missing out on surgical training, sometimes training in their own rotation, in that 6-monthly rotation. That caused frustration among trainees, complaints, eventually led to sickness, burnout of trainees. So the management started thinking, what can we do to improve that? They came up with the idea of having 4 ophthalmic local trainees. At the time, they were unsure of how it would fit, but because there was quite some worries and concerns among the OST trainees that actually the OLT, the CSER trainees, will compete with them on the surgery, on the theater, and they will have actually less theater sessions. Eventually, that was proving to be the other way around, so I'll come to that in a bit. And also, there was lots of locum staff coming into the hospital to cover sessions, clinics. These locum staff, as you know, they're not always with the amount of experience that is required in certain subspecialties, and they were changed at a regular basis, and that required quite a lot of cost, as you can imagine, to the hospital. So in Southampton, they decided to have 4 ophthalmic local trainees, which I was fortunate to be among the first in that rotation. I was the first one to complete the OLT training in Southampton. Southampton was the first unit to pioneer such a program in the UK. I did my training between 2015 and 2020. I had 4.5 years of core ophthalmology training and 1 year of TSC in cornea. I had already ophthalmology training. I wasn't alien to ophthalmology. I had already ophthalmology training elsewhere abroad. And in Southampton, I did 6 monthly rotations in all the subspecialties, and they were all in one hospital, the University Hospital of Southampton. It was all in one hospital. Next slide, please. So in Southampton, I had exactly the same rota as OST trainees. I was doing on-calls. I was doing 1 in 8 on-calls. I was involved and taking part, as every OST trainee, in all educational activities. I was doing audit. I was doing research. We were also having an equivalent to ARCP, which was done at a local level. So we called it yearly ARCP, similar to OST trainees. I was allocated an educational supervisor, a clinical supervisor, and we had a Caesar lead, which we were meeting quite frequently on sometimes even monthly basis. So we make sure that we are up to stage with our performance and meeting our needs, and whether we need any further training or further surgery, and that was tailored to us as well. And we also had to do yearly appraisal, like every other doctor. That, as we know, OST trainees don't have to do that, but as an OLT, as this is not a deanery acknowledged program, we had still to do our yearly appraisal. Next slide, please. So what made this OLT program successful at Southampton was that it was really a genuine program. It was tailored well. We were treated very well as OLT trainees, similar to OST trainees. There was no difference. So we didn't feel as ophthalmic local trainees that we are any less to OST trainees. By management, we are viewed very similar. I get calls quite frequently from Caesar or doctors who wanting to do ophthalmic local training in other units in the country that advertise ophthalmic local training, and they go there, they get promised that they're going to do 6 monthly rotations, and they tell them, okay, let's start with medical retina. They do 6 months of medical retina, and then they need to move to something else, for example, cornea, as they were promised. And then after 6 months, they say, no, we can't move you yet to cornea because we have nobody to cover our medical retina clinics. We have no one to cover our injections. So you've got to stay in medical retina. And as you can imagine, if somebody has moved to another hospital from elsewhere and they were promised that they're going to do something, and suddenly they do end up doing 1 or 2 years of medical retina rotation, that causes frustration, and they end up moving to another hospital and leaving that hospital. So what really made this program successful is that we felt and we were treated exactly the same. We had a similar timetable to OST trainees. We had a protected theater time. We had similar pay. Even when there were pay rises, we're getting the same pay rise, study leave, annual leave, allowance, exactly the same. We have exactly similar time of a yearly ARCP, and above all, we had the support of the management. You know, they saw the outcomes, so they were even more convinced of how essential we are and how that we really should be treated exactly the same. Next slide. So what was the benefit to the hospital of having OLT trainees, and what was the benefit for the OST trainees? We were stable, non-rotating staff. We did all our training at Southampton. So when OST trainees were rotating in August, we didn't. We were the stable staff who knew how things are performed. We knew the IT programs. We knew how consultants like doing their things. So we were actually in that transition period for the first few months when rotations did happen in August. We were the stable staff who were making sure things were happening. Eventually, there was less sick leave among OST trainees because they were less frustrated, they were more motivated, they had their own theater time protected as well, and actually they had more theater time than before the OLT trainees moved, because they didn't need to be pulled out of theater to cover casualty or other clinics. Eventually, there was less locum staff needed, and in 1 year, actually, Southampton has saved £420,000 in locums in that year. Can you imagine how many doctors, OLT level doctors, can you fund with that? And potentially, you know, the OLT trainees that you normally hire, they can be at any level. But the group that we were in Southampton, we had previous ophthalmology training, so we weren't equivalent to OST1, OST2. So that can be of a benefit even to the trust, because we needed actually less training than somebody who's just joining the OST program. So I think you don't need me to convince you anymore of how essential having OLT program at your hospital, especially when there are not enough training numbers in the country and there is immense need for consultants in the UK. Next slide, please. So as the first one to complete the Caesar training in Southampton, there wasn't always guidance available to me, because even in that unit, that was a new program on how to do the Caesar. And there wasn't much information even on websites, or even people who approached were very hesitant to open up and show me their application and what exactly they had done. Because in Caesar, actually, you have to do the competencies and look after yourself, because in OST training, you are in a way, you are being spoon-fed a little bit. You are told what you need to do. In Caesar, no, you have to go and find ways to achieve these competencies, and even sometimes go in your own time and do that. So advice wasn't always available, but eventually I did manage to complete my training. I held a webinar where I opened up my application on the GMC website. And this webinar, just to show you how many ophthalmic local trainee potential candidates you can have, though it was attended by 700 people, where I opened up my application over 3 sessions, and I showed all the competencies that I had to achieve in order to attain Caesar. Eventually, I realized that there were still more questions, and I did write a book on the topic, which was taken very nicely by lots of trainees. Next slide. And nowadays, we have a Caesar, ophthalmology Caesar groups, where there are over 500 people actively in the UK and outside the UK looking to achieve Caesar. There are a few of us there in that group who are mentoring these junior doctors and giving them advice on competencies that they need to achieve and what is the best way to attain their Caesar. So, you know, we have this group which has hundreds of candidates which can potentially benefit many of these units. But above all, it has to be a genuine program where you're offering subspecialty rotations for these trainees, and they've got to move from these subspecialties and you know, understand that there are hospital needs, but if you want to keep that staff with you, you've got to offer them these rotations. You've got to support them in their journey. It has to be mutual. Next slide. So thank you very much. If anybody has any questions, I'm happy to take them. And otherwise, I'm happy to be contacted by email.
Thank you, Ramez. That was brilliant and really, really interesting. Can I just ask you, how do people get a copy of your book then?
It is, if you go to the group, there are, where I put, you can go back to the previous slide and you can join with the QR code. There is a link to where this book can be gotten. Otherwise, you can contact me by email and I will show you a way.
Thank you. I'm just interested to know, do you think that, generally speaking, that if people are enrolled onto the OLT program in their hospital, do they generally finish the CSER program in the same duration that it would take an OST to finish their training, or do you think sometimes it takes longer?
So it can be, it depends. So I know trainees who can do it in 7 years, like OST, and you can do it in less if you can show the competencies. You know, some people have the competencies from other country. The GMC and the Royal College can take those into account. So potentially it can be achieved in less. I know people who've done it in 2 years, but it really depends. I think I wanted most of my evidence from the UK, and that's why I did all my subspecialties in Southampton, and I wanted all my subspecialties from the UK. So, but potentially it can be done in less than 4.5 or 5 years.
It's actually potentially even less, yeah. In your experience, do you think people who do the OLT are more likely to stay in that same unit to become a consultant then? So it's like a longer term investment for the department to have their workforce?
I think yes, because this is a staff that you already know very well. They can potentially be with you for 7 years or 5 years before they complete their training, and you're already familiar with them, you already know them. So I think they are more likely to stay as consultants within that department, especially if you are towards the last 1 or 2 years, you start thinking about jobs and what's available and what are the needs for the department. So for example, if you think, we're probably going to hire a casualty consultant in 1 or 2 years, you can speak to one of the trainees, say whether they have a special interest in that, and maybe tailor their last year of the TSC or towards that direction.
From what you said about your webinar that you held and having 700 people attending, it sounds like there are a lot of doctors who want to do the work and who can do the work. What do you think regulatory bodies, governing bodies, membership organizations could or should do to maybe make that journey easier, or what changes do you think could be made to CSER to make it easier for doctors to gain consultant posts or travel through the system in a bit more easier way?
I think if the Royal College will be able to oversee the ophthalmic local training, the way they can look after the junior trainees, and then maybe, it's very important to keep high standards, but I think one of the main obstacles of the CSER is the application. The application is tedious, it's hard, it's very unclear. If you go to the GMC website, you can see how many uncertainties there are. I think the Royal College can make that process much, much easier, especially if they oversee these programs themselves, and maybe offer a better, easier way to do these applications and make sure that the competencies are met to very high standards as we expect.
Just wanted to put it out there. Does anybody else have any questions? Or I think Bushra, you've got your hand raised, and Professor Burton's put video on as well.
Yeah, I think I'll let Ben speak first.
Well, I wasn't really trying to sort of pull rank or anything. I mean, I agree. It would be nice if we could do this. My understanding is that really it's a kind of what used to be Health Education England, NHS England's kind of job to fund training in the UK, and what they've done is put a lot of funding into trainees and no funding at all into CSER applicants, as far as I can see, and it is disproportionate in my view. I agree there's an issue there. Maybe we can get you to volunteer to come and help the college, because it's all done voluntarily. There's so we need people like yourself perhaps to come and help set up a.
By all means, I'll be glad.
Yeah.
By all means.
Yeah, I think my comment was along the same lines, that the process should be fair, and there should be parity. I mean, if because a lot of my fellows and successfully at Birmingham Middle Eye Centre, we have taken people through CSER who have finished the CSER and been appointed consultants. The application seems to be the stumbling block, not because of its complexity, because of its, as you say, it sort of its ambiguous elements, which people, think that, it's deliberately there to make them fall. So I think even that process needs to be looked at, and just to make sure that it is much clearer what the ask is, keeping the high standards. At the same time, the language that is used in the form, maybe it should be clearer. And I think college could Ben, what do you think? This is something that
they've actually, the GMC's just changed. So the GMC sets the rules, and they've just changed the kind of, not quite the criteria for but I mean, Sarah Mailing knows more about it than I do, but the rules have been kind of like freed up a little bit. So, for example, the time constraints on having done your paediatric bit within 5 years is now, there's a bit more fluidity about that. It's not like a hard cut off, and then you have to do your paediatrics again if you haven't done it in time. I think it's certainly been extended to 7 years, but there's also some sort of leeway where maybe if you did paediatrics 10 years ago, but you can do 2 or 3 squints, you don't have to do 30 squints or whatever the current number is. So there's some movement. I mean, the other thing that worries me, you'll be surprised to hear me talk about the problems and issues with the independent sector again, but is that we're talking about independent sector training. We're only talking about training of trainees in the independent sector, and for my unit, 2 of our consultants did the CSER route with us, and we've got other people doing CSER with us at the moment. But if we don't have enough cataracts to train people doing the CSER route, then we're going to lose them. They'll go and work in Canada or New Zealand or somewhere, and then we'll have nobody to run our on-call on the rotas and nobody to do our glaucoma clinics and so on. So the whole system's at risk. So to me, it's a big issue, and it goes well. The independent sectors. We need to get them not just training trainees, but training CSER candidates, training SAS or letting SAS doctors do service lists to keep their numbers up and their interest up, keeping consultants doing big enough numbers that they don't get de-skilled just doing 6 difficult cases a week or every 2 weeks in my case, or okay, 8, but anyway, same difference. It's it's an issue. Anyway, so I'll shut up.
Yeah, a lot to talk about, especially the cataract one and its long-term impact on training and workforce, as you've rightly mentioned. I think this is something that the government and the commissioners need to be, I'm sure they're being advised, but time is of the essence. If we lose those skills and the will to stay and get trained, we will have, even bigger exodus. Right, I'll be quiet now. Back to you, Sunil.
Well, yeah, I mean, thank you very much for those inputs. And just to say, we're almost at the end of the meeting now. So it's been brilliant having all of these speakers. All the talks were absolutely brilliant. And I hope that everyone who's attended has enjoyed the meeting and will be able to come to our next meeting as well. Has anyone got any final questions for any of the speakers at all?
Just while people are thinking, can I just make a point that, if you're in a unit where you're struggling to recruit people, then laying on your own CSER programme is quite a good way to attract people, and that's one of the things that we've done in Great Yarmouth, which wasn't the top of people's go-to list 17 years ago when I started, although it's quite high up for some people now.
And how do you find? Do you have any difficulties with recruitment now that you've opened that, or do you think that solved a lot of problems?
Well, so the helping people through CSER and getting a reputation for that has definitely helped. As the other chap was saying, prioritising training and protecting study training time, making sure everybody gets a list. We had a cataract simulator. We do a bit of research. That we want to make the unit kind of focused on being a good experience for patients and our team, and not be too distracted by private work or the independent sector or whatever.
Well, I think we'll close the meeting there, and look forward to seeing everybody at the next meeting. And yeah, so great. Tell everyone else to watch the meeting if they haven't online afterwards. Okay.
Great meeting. Thanks. Bye.
Bye, everyone.